Hello everybody. Today we are going to discuss about the non-occlusive mesenteric ischemia. So acute mesenteric ischemia is the major complication in critically ill patient and encompasses two different pathophysiological entities. The occlusion of large mesenteric arteries or vein due to arterial embolism or local thrombotic process is referred to as occlusive AMI. The other entity, so-called non-occlusive mesenteric ischemia, occurs despite preserved patency of large mesenteric vessels. Non-occlusive mesenteric ischemia was first described in 1958. It is devastating disease that accounts for 20 to 30% of all cases of acute mesenteric ischemia. Importantly, NOMI is the common complication in critically ill patients with acute circulatory failure and accounts for major cause of death in the intensive care unit. In the large multicenter study of 780 ICU patients with AMI, the overall mortality rate was 58%. Trumpeter et al. Reported the high mortality rate of 50 to 80% in patients with the norm. Mitsuyoshi et al. Described the mortality rate of 70 to 90% that has not changed over time. So we'll see what are the risk factors. Age older than 50 years, ischemic heart disease, chronic renal disease, cirrhosis of liver, peripheral artery disease, low output cardiac condition like acute myocardial infarction with shock, congestive heart failure, arrhythmia, drugs like catecholamine, diuretic, digitalis, circulatory failure, shock and dehydration, major abdominal or heart surgery, hypovolemia like pancreatitis, hemorrhage and sepsis. Pathophysiology, non-occlusive mesenteric ischemia is the result of splanchnic hypoperfusion commonly caused by circulatory failure. A decrease of approximately 50% of the blood flow through superior mesenteric artery respond to the compensatory vasodilation. If this low flow persists for several hours through superior mesenteric artery, this compensation ceases to be effective and the phase of mesenteric vasoconstriction begins with the progressive increase of vascular resistance. In case of splanchnic vasoconstriction lasts for more than few hours, it becomes irreversible even if 100% of the blood flow through superior mesenteric artery is re-established. The advent of NOMI causes intestinal hypoxia in the setting of increased intestinal metabolic demand, ischemia, reperfusion, injury, apoptosis, and decreased proliferation of enterocyte. This lead to tissue necrosis, disruption of intestinal barrier, which may then result in bacterial translocation, systemic inflammatory response, and multi-organ failure. Pathological findings include neutrophil and fibrin infiltration of serosal surface, severe and edema, hemorrhage, blood stasis of intestinal submucosa. Now about diagnosis. Diagnosis and the treatment of acute mesenteric ischemia rely on the timely multidisciplinary management involving intensive care physician, gastroenterologist, radiologist, and surgeon. The clinical features of the NOMI include abdominal pain, nausea, vomiting, and ileus. Abdominal pain could be severely out of proportion compared to the physical examination finding. This may be complaint of postprandial abdominal pain as a enteral nutrition tend to increase gut blood flow demand, which can lead to worsening of mesenteric arterial ischemia in patients who are already hemodynamically unstable. As there is progression of the disease to bowel necrosis, the physical finding reveal distended rigid abdomen with the rebound tenderness. However, in severely ill ICU patients, particularly those on ventilator and requiring sedation, clinical signs and symptoms are very difficult to assess. In retrospective study, which included 113 patients with acute mesenteric ischemia, 12% of patients were shown to have NOMI with no abdominal pain in 23%. The lab investigation may demonstrate lactic acidosis and leukocytosis. Clinical symptoms and the lab investigation lack sensitivity and specificity in this setting. With the result, usually during diagnostic process, the disease slowly advances into irreversible state with extensive intestinal necrosis. Now about angiography. Selective digital substantial angiography of mesenteric arteries is the gold standard for the diagnosis of NOM. A patent proximal mesenteric trunk with no signs of thrombotic and embolic occlusion and diffuse peripheral vasospasm are features that led to definitive diagnosis of NOM. Although DSA is the gold standard, it is difficult to perform angiography in such a critically ill patient. Also, in patient with the acute abdominal finding, the presence of peritoneal sign may be an indication of bowel infarction needing laparoscopy. So, this is the angiogram of superior mesenteric artery showing diffuse spasm, and the findings are narrowing at the origin of major mesenteric branches, irregularities at the origin of SMA branches, spasm of arcade of the mesenteric artery, and impaired feeling of intramural vessel. Now, contrast enhanced CT of abdomen. CCT allows for evaluation of arterial and the venous mesenteric vessel and presence of intestinal necrosis. So, CCT is quick and easily accessible and should be performed at earliest in all cases with suspicion of AMI. Now, the contrast enhanced CT findings are common to both small and large bowel, absence of mesenteric torsion, dilated intestinal segment, flaccid and thin-walled, poorly visualized with contrast, patent proximal mesenteric trunk, no signs of thrombi or emboli, small bowel non-occlusive ischemia, there is a lack of wall enhancement, pneumatosis intestinalis, portal venous gas. Large bowel non-occlusive ischemia shows the mural thickening, pericolic fat stranding, mucosal hyperenhancement, solid organ infarction, and bowel perforation. So this is the CT axial imaging showing the dilated small bowel loop with the air within this wall, suggestive of pneumatosis. The other picture is showing CT axial image showing the air within the portal venous system. Now, laparotomy finding, confirmatory diagnosis as well as assessment of the extent of necrosis commonly involves direct visualization of alimentary tract by endoscopy or by surgical exploration as plain X-rays. Duplex sonography, CT and magnetic resonance imaging have limited value. Characteristic of the gut necrosis are invariably present in patients who undergo laparotomy. NOMI is characterized by the non-continuous segmental necrosis in which mesenteric flow may be retained even in the marginal arteries reaching the lesion, despite extensive necrotization throughout the intestine. This is marked distinguishing feature from the occlusive acute mesenteric ischemia, in which mesentery and intestine are necrotized from the site of thrombus, forming sphenoidal necrotic area in the region served by the artery, resulting in continuous necrosis. Now, features of the NOMI during exploratory laparotomy. That is, peritonitis is found, peritonitis in 15% patient, perforation in 14%, peritoneal effusion 48%, necrosis 54%, non-necrotic ischemic lesion 16%. Now about extent of ischemia, if it is extensive, that is more than 2 intestinal segment, 28%, segmental 42%. About management, therapeutic option for NOMI vary depending on the time interval between symptom onset and the time at which patients seek medical care. If ischemia time is less than 6 hours, vasodilator such as papaverine may be infused angiographic. If ischemia time exceeds 12 hours, vasodilator therapy such as nitroglycerin is initiated, but first look surgical exploration should be considered to perform resection of involved gut if peritonitis is present. Many reports suggest the expeditious surgery is the key to successful NOMI treatment. The presence of CT sign of portal venous gas or pneumatosis intestinalis definitely indicate the need for urgent laparotomy, exploratory laparotomy, which should probably also apply to the abnormal wall enhancement. The question remains unanswered about surgical indication in patient where negative abdominal imaging, which is not uncommon even in the presence of gut necrosis. Although it is difficult to offer firm recommendation, the surgical indication should be based on eventual clinical deterioration despite optimal medical treatment and advanced organ failure support. Finally, the consensus is that most important treatment for NOMI is preventive, and every effort should be made to limit duration and severity of acute circulatory failure. Thank you, guys.